Welcome to the Queensland Fertility Group webinar. This is my very first webinar. My name is Gary Swift. I'm one of the senior specialists at QFG Gold Coast. I've been a fertility specialist for 20 years and part of a group that sort of runs the Gold Coast unit, which is part of a much bigger Virtus Health network. Tonight's webinar is about basically all you need to know about fertility, and I'm going to go through a set slideshow, which is a sort of structured program that is put out by the Virtus group, and I will at the end answer any questions that we possibly can to help you understand what's factors that may affect sort of fertility, and I'm very happy to answer any questions that you might have. But just to, I suppose, a little bit of background. As I said, I'm a specialist obstetrician gynecologist. I've been a specialist for 20 years. I've worked in fertility for over 20 years. You know that some gynecologists deal with cancer or waterworks or prolapse, and there's a group of us who deal with reproductive medicine, which are couples who are trying to fall pregnant. And within that group, there's some of us who both try and help you fall pregnant, but then look after the pregnancies and see them through to completion as well. I have a particular interest in endometriosis, and I had especially trained in laparoscopic surgery, and that's my sort of bias. And I sort of maintain my sort of skill set in that area, but as well as dealing with all sort of aspects of infertility. So without any further ado, I'll go through the slideshow presentation, and hopefully you'll find this beneficial for you. So just any sort of discussion about falling pregnant and having babies, making babies, is always got to start with pre-pregnancy health. So it's vitally important that you prepare your body, both male and female partners in a couple, and a few sort of key things to look at specifically. Caffeine in small doses is safe, but in big doses it sort of works against you. Like same with alcohol, an occasional drink won't do you any harm. And for men, probably they get 2 standard drinks a day, won't interfere with sperm production, but excessive consumption, particularly without a break. And I tend to sort of say that couples should probably have 2 alcohol-free days every week, as well as an occasional night out. Obviously doesn't hurt, and I'm sure there's lots of babies conceived from more than these occasional nights out. But when you're actually focusing on getting pregnant, particularly if there's a few things that are not happening as easily as they should, then certainly being moderate about alcohol intake is important. Same with having a healthy diet, balancing the 5 food groups, staying away from low value foods, and particularly having plenty of sort of vegetables, salads, moderate amount of sort of red meat, but also sort of fish, and balancing your diet across the food groups. And as I said, minimising sort of low value foods, the fried foods, high sort of carbohydrate foods. Exercise is important. You don't have to go to extremes with regards to exercise, but keeping fit and aiming for an ideal body mass index and staying healthy is the target. I tell couples that, you know, male and female, that when they have an exercise program, you should feel invigorated at the end of it. You shouldn't come home and feel exhausted and sort of push yourself to extremes. And likewise, people who play sport need to be careful that they don't go to sort of extremes. And we do see some challenges with fertility in men and women who are sort of like ultra marathon runners and triathletes who maintain very low body fat. So there's 2 ends to a healthy spectrum with BMI. Cigarettes in all sort of scenarios have a negative effect. They're full of poisons, and they reduce fertility for both men and women, as well as complicating pregnancies and potentially creating low birth weight babies, poor placentas, and having sort of longer term health issues. So in that sort of framework, so who has difficulty falling pregnant? So we're all sort of told in high school that if you're not careful, that you'll fall pregnant really easily, and you've got to be sort of super careful. Everyone needs contraception. The realities are that couples who are trying to fall pregnant won't always sort of find it happens very easily. And by definition for us, 1 in 6 couples we classify as subfertile in that they need assistance in conceiving. So that's about 15%, which is a significant number, proportion of the population. So some of those will have major challenges and some will have relatively minor challenges that just need a little bit of sort of advice or coaching or relatively minor interventions. We know that there are both male and female related issues. Women tend to be a little bit more complicated because there's two major arms, issues related to the ovaries, egg supply, ovulation, as well as the anatomy of the pelvis, including sort of the uterine and tubal diseases. Men tend to sort of have a relatively sort of simple process. They're making the right sort of balance of sperm with numbers and motility and morphology, or they're not. And there are some things that are reversible, but a lot of things that aren't. And as with a lot of things in medicine, and particularly in this scenario, it often takes two to tango. So just because a couple's aren't fully pregnant, there's no definite sort of point the finger at one or another, because often there's a contribution on both accounts, and that's certainly for 30 to 40% of couples. And then unfortunately we still get a challenge where we've got about another 1 in 6 couples, or about 15%, who have unexplained infertility, which means that there is ultimately a cause, but we just can't find it. And sometimes as we progress through investigations and even using IVF technologies, that we actually do find a cause at the end related to fertility. But in the early stages, we have a group with unexplained infertility, and the approach to them is slightly different because we don't know exactly what we're tackling to start with. So where to? So we know that the chance of falling pregnant every month is about 22% for a healthy couple under 35. It falls significantly once you get over 35, particularly with the female partner. So the actual jumping to say, when do you actually start thinking about a medical consultation to look into what may or may not be going wrong with you, we draw the line sort of at 6 months over 35, whereas we're happy to often sit for 12 months in couples under 35, unless there's an obvious reason, such as heavy painful periods, which might suggest endometriosis, a history of infection, or known abnormalities in the family. In that scenario, we tend to investigate things much quicker. So there's no absolute musts, and certainly if delay in conceiving is causing anxiety or worry, then an early recourse to at least a beginning workup and a few simple tests is probably a good plan. So what do we do? Now, generally speaking, you get a referral from your general practitioner to see a specialist. If you're seeing a specialist that works in the assisted reproductive areas, then we will go through in a methodical fashion with both the male and female partners the whole medical and fertility history of both partners. Now, it is, in women, it's quite a detailed history, starting from when periods started, how often they occur, whether there were problems in the teenage years that might sort of signify early onset endometriosis, particularly painful periods, heavy periods, missing school with periods. Then there's risk as you sort of late teens into 20s. Have there been sort of episodes of sexually transmitted diseases that might affect the pelvic organs and the way they function? And then as the move through 20s and 30s, are there other acquired conditions such as fibroids, polyps, other sort of pathologies that might impact on how the sort of reproductive tract works? Same with men. We want to make sure they haven't had undescended testes, major trauma to the testes, torsion, twisting, or any family history of sort of reproductive problems that might sort of imply that further testing is needed. Mumps in boys before puberty tends to be sort of a relatively benign disease affecting the parotid glands. Mumps after puberty for boys can often involve an inflammation of the testis and damage the sperm producing mechanism. So we're looking for those things in the history. So there are specific things that alert us to common conditions. So in women, heavy painful periods or even frequent or irregular periods may signify another condition called polycystic ovaries, which is very common. Whereas in men, as I said, there may be a history that's suggestive, but in often cases you can't actually tell for sure, what might be a problem with men. And I always say you can't just look at him and say he looks great, so his sperm's going to be good. So in reality, we've got to sort of investigate and make sure there's not a problem. The general health is always incredibly important. any sort of systemic disease can actually secondarily impair fertility, particularly if it impairs nutrition, activity, BMI, or general health. The body tends to preserve the vital functions, and reproduction is not one of those vital functions. So being generally healthy is important. So from a specialist point of view, there's always basic tests that we need to do in the beginning. And I always tell couples that there are the fundamental tests which give us the cornerstone of the information for reproductive assessment is a semen analysis for men. So we need to know whether he's making normal sperm numbers, normal concentration, whether they're swimming properly, whether they look normal. And in women, we really know whether they're ovulating regularly. And whether there's anything that sort of suggests that there's a problem with their egg reserve or their anatomy that might sort of impact on the chances of a sperm and egg sort of fertilizing. So that's the sort of general approach we take in the first instance. Now, to focus on women first, certainly assessing the ovarian reserve and looking at the sort of the pre-pregnancy workup focus is where we start. So anyone wanting to fall pregnant, there's a panel of infectious disease screening and general tests we do, and they include rubella, syphilis, Hep B, Hep C, HIV. We check blood groups, antibody screen, we do a blood count. These days we often look at the thyroid function, and in sort of certain ethnic groups we'll do special testing to look for any disease processes that might sort of impact on pregnancy or might require vaccination or attention before embarking on a pregnancy. And they're sort of across the board. We also want to look at sort of the pituitary function, whether there might be an imbalance, sometimes testosterone, prolactin, other hormones in the system, which might imply not normal functioning of the pituitary axis. An ultrasound scan is going to give us an anatomical assessment of the uterus. It'll allow us to look for fibroids, polyps, abnormalities in the shape or structure of the uterus, and it'll show us the ovaries and give us an idea of egg follicle reserve, whether there's any problems with the ovaries, lumps, bumps, tumours, things like endometriomas or something which might actually disturb the ovarian reserve or actually impact on the potential normal functioning of the ovaries. There's a blood test we could also do called an AMH, or anti-Müllerian hormone. It's a measure of egg reserve, and it's a simple blood test that between women between sort of 25 and 50, we've got graphs that show quite clearly where the egg population should sit in the centiles. We know, as per the graph on the screen, that we know that women's ovaries fill up with eggs just about 3 months before they're born, and there's about sort of 4 million or even more eggs in the ovaries, and they very rapidly after the ovaries are populated by very primitive oocytes or eggs, that they start to decline, so that even by birth there's probably 1 million eggs in each ovary for most women, and even before puberty, when the cycle starts, those 2 million eggs have dropped down to 400,000, so that between puberty and menopause, there's only a very rapid depletion of egg reserves. So there's a certain group of women who might get less eggs in the beginning or lose their eggs more rapidly that we want to identify, because if they've got a low egg reserve and they're hoping for more than one pregnancy, then there's often we need to accelerate things to help conception occur faster than nature would otherwise allow. The things we worry about women obviously are blocked or damaged tubes, and that's nearly always from sort of infections, some sexually transmitted infections, some surgical infections, appendicitis, peritonitis. There's 2 conditions which affect about 10% of the reproductive age women. Polycystic ovarian syndrome, where women often have a good population of eggs and often higher than average in the AMH readings, but they don't release their eggs very regularly. And in that scenario, we've often got to intervene and help oocyte development and release with either tablets or sometimes injections. Endometriosis is the other one, which affects 10% of women of reproductive years, and it's quite a nasty disease where the lining tissue of the uterus goes outside the uterus and it causes scarring, distortion, adhesion, can actually obstruct fallopian tubes, and the actual presence of the disease can reduce ovarian reserve, can interfere with almost all the steps of egg development and production, release, and ovarian sort of tubal transport, fertilisation. So it's quite a nasty disease, particularly in its more severe forms. Fibroids are benign tumours that grow in the wall of the uterus, and particularly if they distort the cavity of the uterus, they can push the uterus out of shape and have a substantial reduction in the chance of an embryo implanting in the uterus. And there are some women who may have eggs in the ovaries, but they just, for whatever reason, just are not releasing the eggs. So there's a failure of ovulation, which is a crucial step. On the male side of things, semen analysis is the cornerstone, as I mentioned before. Healthy men should be making more than 15 million per mil sperm concentration. They should have 30% swimming in a rapid progressive mode, movement, and they should have at least 4%, which are morphologically normal forms, and ideally less than 10% of anti-sperm antibodies, which are the proteins which bind to sperm. Now, we know that when we do a semen analysis, we're getting a snapshot of men. We know that that may not be their best or their worst, and we know that, as per this graph, which is a classical graph where a scientist did his own semen analysis every week, and you can see the count varies from being very, very high to even sort of very, very low, almost zero on occasion in an otherwise healthy male. So we use what's called the World Health Organization fifth centile, so that even those numbers I mentioned before, 15 million per mil, 32% and 4%, are still 95% of men are over those numbers, but 5% of men who father children actually have fewer than those numbers. But they do impact on the chance of success, and certainly when you combine abnormalities with further abnormalities on the female side of the equation, then you start compounding factors that reduce fertility and impair conception. So, as I said, low numbers or poor motility are important. If a lot of the sperm have abnormal shapes, particularly if the heads are abnormal, because it's the sperm heads that actually bind onto the egg to actually deliver the genetic load, so that an egg can actually be fertilized by a healthy sperm. And so if there's more sperm that have abnormalities, then they either can't swim properly or can't get to the egg or can't do their job when they do get there. Antibodies in the system, and particularly men who've had vasectomies or major trauma to the testes, particularly ruptured testicles or some, can actually develop antibodies, which actually like little proteins like lead weights, so that the sperm have trouble swimming and functioning normal. There are a small number of men who carry a gene, which is part of the cystic fibrosis group, in which the vas deferens, or the tubes that carry sperm from the testis to the penis and in the ejaculate, are either blocked or absent. So infection can block them, or congenital absence can occur with the cystic fibrosis. And that means that even if there is sperm production, then the sperm can't get to the ejaculate and therefore can't swim up to the eggs. And there are some men who simply have testicular failure, and we see it sometimes in men who use anabolic steroids for prolonged periods of time. We see it if there's been major damage to the testicles. We see it in some men who've got genetic abnormalities, missing parts of the Y chromosome, or actually rearrangements of chromosomes where there's a pure failure of sperm production. And in those men, sometimes it's reversible, but if it's not reversible, then it's when we sort of lean towards donor sperm or other options for couples. So after these preliminary tests are done, particularly looking for the basics and looking for some reason or direction why fertility, or conception hasn't occurred, then we've got to get you back to the office and go through the results. And once we've got those results, we've got to talk about treatment options. So not everybody needs intervention. Some couples need advice. Some need to be told that there isn't anything wrong, that continuing on the path that they're taking may ultimately lead to success, particularly if age is on this side. It's a little bit less reassuring when age is coming into the equation significantly. So treatment options can vary between relatively minor interventions to significant interventions, up to the sort of probably the most interventions that we do, which is with IVF technologies. But we need a plan, and we need to diffuse the whole issue of time and that panic of waiting every month for a period and feeling depressed when a period comes, and then sort of moving on to the next one. And it can really be a significant physical and psychological impediment when that occurs. So, but again, considering the age, the etiology, the wishes, the number of children, the time frame, then we need to sit down and sort of say, look, what do we need to do to help? And there are very few instances where we can't help. And there are few instances where we've got to say, look, it's a really, it's a challenge, and advanced maternal age is probably the biggest challenge that we face, because we can't make eggs younger or better. But it's really very much an individualised step in the process, and that can involve just monitoring the ovarian cycle and seeing exactly when an egg is being reduced, being released, and making sure that process is actually happening. And if it's not happening, then we start looking at medications, either oral or injectables, called ovulation induction agents. And for a long time, we used clomiphene, or Clomid, it's known as. Nowadays, we're using letrozole, which is actually an anti-estrogen breast cancer drug, but we use it in short bursts. And we've now found that it seems to be more effective than clomiphene in that we're getting more pregnancies and we're getting less multiple pregnancies, which is a good achievement. But not everyone is going to be sensitive to it. So some women, despite attempts with oral medication, sometimes need injectable FSH, the same hormone that the pituitary makes, each month to send down and stimulate ovaries to make egg follicles. And sometimes we've got to give that in small doses to just make 1 or 2 egg follicles grow. Whereas if we give doses as we do in IVF cycles, we know we can often make sort of multiple follicles grow. And whether we combine that process with what's called intrauterine insemination, where we actually get a semen specimen from the male partner, centrifuge it down into a very concentrated specimen, and then squirt it up through the cervix into the upper part of the uterus at a time in the cycle where we know the egg is about to be released, so that the sperm can be swimming up and waiting. We know that this has a positive effect in unexplained infertility. It can help with minor tubal disease, but it's obviously useless in obstructed fallopian tubes. It can make a difference to couples with mild endometriosis who are struggling to conceive, but it's probably has a probably fairly small chance of helping in severe endometriosis. It tends to be most effective when the age of the female partner is under 40. And obviously it's an important step in donor sperm recipients. So couples where the male partner doesn't make sperm or has lost the ability to make sperm, or even same-sex couples who choose donor sperm to help them fall pregnant. And we can use it, not only with ovulation induction, but it can be used in part of a natural cycle. And the classic things we see often on the Gold Coast is where the male partner is a fly-in, fly-out, or works on oil rigs or away, so that we can store sperm frozen in the lab, and if the female partner happens to be fertile when hubby's away, then we can thaw sperm and use IUI to actually inject the thawed partner sperm, so they don't actually miss cycles as much as they would otherwise just by the work schedules. And then, of course, there's the top end of the scale. There's when we need to take over the whole process. There's IVF, which is in vitro fertilization, and that just means literally fertilizing eggs in the laboratory, and then the process called ICSI, or intracytoplasmic sperm injection, where we actually, rather than allowing eggs and sperm to meet and fertilize together, we're actually force fertilizing the eggs by injecting the sperm inside. And that's a process which we need to do if men have very poor motility or sperm abnormalities, or if we retrieve sperm directly from the testes, because they can't swim and they don't have the ability to bind on and what's called capacitate or fertilise the eggs. So in that scenario, ICSI is essential. We were worried that we might be bypassing natural selection early on, but it's been around for a long time now, and we're quite confident that we're not actually tinkering with the ultimate balance of genetic disease in nature. So it's quite a reassuring and very important technology to use. So the process once we get up to IVF and ICSI, it starts to involve multiple members of the team. There's an initial discussion with a nurse practitioner who goes through every step in minute detail and how to use the pen injectors. The pen injectors, which carry FSH, will deliver the hormonal load to stimulate the egg follicles to grow. And then once we're on a cycle, we've got somewhere between 8 and 12 days of injections, and we've got to monitor the response of the ovaries and the eggs by blood tests and ultrasounds. And then ultimately, once the ovaries have been stimulated and multiple follicles have grown, Then there's a procedure which is an ultrasound guided procedure, often under an anaesthetic, a light general anaesthetic, but occasionally under local. We actually pass a needle up behind the vagina and aspirate the follicles and retrieve the eggs. And once we've got eggs and sperm, then fertilisation, either naturally or by ICSI, occurs. And then these days we try and grow embryos for 5 days till they reach the blastocyst stage before we sort of choose the embryo to transfer. The egg collection is a bit of an invasive procedure, but it's vital to actually get the eggs when we've got more than one egg, or there's absent or blocked fallopian tubes, or when we're using IVF technologies or even genetic technologies. It's an essential step to actually get the outs that we can use them and create embryos. And then when we're putting eggs and sperm together, we're putting about 20,000 sperm next to each individual egg. So if we get a dozen eggs, we put a droplet with each egg, and then we sort of wait 24 hours to see how many fertilise. And then the actual sort of early human development is a fascinating process. But we see fertilisation of the egg, we see cells divide every 24 hours, and ideally they reach, by day 5 or morning of day 6, a blastocyst phase, which is this development in nature occurs along the fallopian tube, and in IVF it occurs in the laboratory. And with some newer technologies, particularly embryoscope technologies with time-lapse photography, we can actually watch these sort of cell divisions occur and make sure they happen in the right pattern at the right timing, so that we can help decide which of these blastocysts actually have the right genetic makeup to turn into a baby. Because we know that even though this stage is fascinating, that's as far as we can grow embryos in the laboratory. And even that stage, there are still, unfortunately, some embryos which won't implant or implant and then miscarry. So it's still the holy grail for us to pick the right ones to put in and that'll turn into babies. So expectations, when we undertake an IVF cycle, most of us try and get a dozen or so eggs to grow. Sometimes we get more, sometimes less. We know that if we get a dozen follicles, we might get 9 or 10 eggs. They may not all be mature and they may not all fertilise. And once they fertilise, they don't always divide. And once we get to sort of that day 5, we might have started with a dozen follicles, but we might only end up with sort of 3 or 4 embryos to choose from to actually transfer, and then the leftover ones which we don't transfer. This day and age, we would normally sort of cryopreserve or freeze. They get snap frozen. We know that 95% of snap frozen embryos these days will survive the freeze-thaw process, and then we can use them in subsequent cycles without going through the whole stimulation steps to the whole egg retrieval pattern. The transfer itself is similar to a pap smear, where a little tiny catheter is threaded through the cervix. The embryo is the size of a speck. It's loaded by the scientists into an inner transfer catheter, and often these times with an ultrasound guidance, we actually place that little embryo in a droplet of fluid in the top part of the cavity, about 1 centimetre from the top of the fundus of the uterus. Although that sort of slide says return to normal activities immediately, most of us would say have a quiet day that day. We don't sort of push you straight off the bed and out the door. We tend to say just stay relaxed. A lot of couples these days will have acupuncture before or after, just sort of to stay relaxed and keep their bodies in a sort of a calm, receptive phase. And certainly most of the times we'd say have a quiet day that day, and even the next day sometime, just to let nature literally take its course with regards to implantation. Freezing, as I said, vitrification is snap freezing. We can freeze embryos, eggs and sperm for 10 years. There's nothing bad happens at 10 years, but that's when we've got to sort of reappraise, do we keep them from there? And most biological products, have come to sort of use within that 10-year time frame. The only scenario is when we're taking eggs from young women who have cancer or have chemotherapy, and they're the group that we'll probably keep for longer than 10 years. But generally speaking, 10 is what we aim for. And obviously the big wait after any embryo transfer is for that pregnancy test. And we know that after an embryo is transferred, which is usually on day 5, we've still got to wait to the equivalent of when the next period would occur. And that's usually about 9 days before we can sort of detect a positive pregnancy test. So 10 to 14 is probably a little bit sort of on the longer side, but as soon as you hit that, period should have come. hopefully the period hasn't come, and that's when we're doing a blood test. But it still is a wait, and it's still, you know, a long time to wait. And success, obviously, ultimately, the whole process is based on the fact that you want to go home with a healthy baby after you go through the process. And that does depend a lot on the age, and age of the mothers more important than the age of the fathers. And you'll see by those sort of graphs there, and they're the sort of QFG statistics from both the central and regional labs. It's a very high chance for couples under 30 and even under 35. Is almost a 1 in 3 chance that you would expect to go home with a live-born child after an IVF cycle. But it means 2/3 don't. So we often need to do more than one cycle to get you over the line. And sadly, that the eggs are, the less likely they are to turn into babies, and the more likely they are to have little mistakes in them that may lead to miscarriage or unsuccessful cycles. There's a few other little tricks these days. Selecting the best eggs, best sperm, best embryos. There are genetic testing of embryos to go through. There is, as I said, time-lapse photography. All of these sort of things, these little tricks and techniques in the laboratory are ultimately designed to help to get that best embryo to give the best chance for a baby, and that's where the sort of the QFG scientists really come into their own. QFG also has a donor program, so not everyone, as I said, can have their own sperm. Single women, same-sex female couples, and men who sort of have disease or disorders where they don't produce sperm will often need to retrieve sperm. We have local donors. We import sperm because there's not enough Australian donors to cover demand. Eggs are a bit trickier because women have to go through the first half of an IVF cycle to actually have their eggs retrieved. So there are less donors. There's a few altruistic donors, but most egg donors come from sort of close family, friends, or relatives. But there are certainly women out there who choose to donate, and they're fabulously generous with their sort of their body and their time. Embryos come up to the donor program when couples have achieved their ideal family size and have leftover embryos, and they choose to donate them. And QFG tries to sort of move those embryos towards couples in a sort of very fair and orderly fashion, but there's always more demand than there are embryos. Surrogacy is a whole different sort of webinar, but there are some women who literally cannot carry their babies either because the uterus is no good or been removed, or there's a disease process or cancer. But if they've got their own eggs, they can fertilise them with husband's sperm, and then those embryos can then be carried by a third party, another woman, who will carry the baby, and then in a complex process of adoption, bubs will go back to hopefully the initial parents, and that's a very complex scenario. And as I said, it's a whole webinar in itself. In this day and age, there's many more women who are choosing to have babies on their own if they haven't met Mr. Right at the right time in their lives. They're accessing donor sperm. Same-sex female couples are an ever-increasing part of our sort of workload. And we know that psychologically and in all sort of sense that the kids from same-sex couples, families are equally well-adjusted and healthy kids. So we're very supportive in that regard. Same-sex male couples are a little bit more complex because they obviously require a female surrogate. So there's a much more complex process. And in that scenario, we can facilitate or direct, but there's less that we can do under the sort of current sort of legal and framework in Australia. But donors, as I said, can be de-identified. Some couples use their own donors, which then have sperm collected, and the sperm quarantine against infectious diseases for up to 6 months. And then, as I said, different scenarios, whether IVF, IUIs with same-sex couples or single women. And then, as I said, there's a lot of sort of same-sex couples now, female couples, who end up sort of using the same sperm donor but using their own eggs. And there are some couples who may or may not be able to, one partner can carry a child, one can't. So it becomes very complex. But we make all sorts of families, and as I said, very keen, very supportive. We don't think that single women or same-sex couples need to be isolated into special purpose clinics. We think they should be treated same as every other couple that turns up for care. So, and that's how the QFG model works for us. I know other organisations treat things differently. but that's not us. We're equal opportunists. So fertility preservation in this day and age, again, a bigger part of our workload is actually taking women who haven't partnered or aren't ready to have babies because of either career or other priorities, and they know that their eggs are going to become less viable and less likely to turn into babies as they age. So nowadays you can choose at a younger age, when your eggs are potentially better quality, more likely to turn into babies, to actually take those eggs out and freeze them and have them sort of available, as I said, for at least 10 years for future use. And it's called reproductive insurance. So some women who know they have endometriosis or reduced reserve will do it, particularly for fertility preservation. Some women who need to undergo chemotherapy for cancers or other things will do that specifically before there's potential damage to their eggs. But certainly in this environment, women, ideally somewhere between 30 and 35 who aren't planning children in the near future should seriously consider having eggs retrieved, frozen and cryopreserved. It takes away the risks of poor fertility or down the track, and look, the technology exists and it's very effective. The expense is the main limiting factor. It's not a cheap process, but obviously the ultimate sort of goal of having a child and preparing for a time when your eggs are too old to make babies is the driving force behind it. So who are we, QFG? Look, in this day and age also, there are multiple organisations, multiple groups performing IVF and assisted reproductive services. We just simply think we're the best. We've got the biggest network. We think we've got the best team, the best doctors, the best scientists, and we think we can sort of deliver this service better. We're particularly enthusiastic, and we do everything we can to help couples achieve their dreams, basically. And then for those of us who do obstetrics as well, we get to see the dream go further and hopefully the baby's born. So that's who we are, that's where we are. qfg.com.au is all the information you could possibly need. And then obviously to see a specialist, GPs will direct you, provide contact referrals, and that's how it works from here. So for those of you who've tuned in, thank you very much for taking the time to listen to me. I hope it's been helpful. If we can help, as I said, QFG Gold Coast, we're at Pindara Place at Benoa. We can always help with the with the sort of the workup and the sort of setting up of things. We can sort of take you from everything to nothing. There is a question: do you have a BMI limit? Look, there is BMI is an important factor for both the health of the mother going through pregnancy and some of the practicalities of the procedures that we do. Generally speaking, in our day surgery unit, we have to have a BMI limit of 40, which is still fairly heavy. We can do women who are larger in the main theatre complex at Pindara Private Hospital. So I suppose when we get to our BMI considerations, we've got to sort of say, are you at a safe BMI to have a baby? Are there risks to you or to the baby of pregnancy? So we try and individualise that approach to things. Once we're getting over 50, we're starting to get concerned about sort of significant risks, health risks. But I think everything's individualised. Another question: how many cycles of IUI do you recommend before IVF? So, excuse me. I might just have a drink of water. So if we are looking at a scenario, age is important. If there's a normal uterus, fallopian tube and sperm, we know that the chance of IUI being successful is about 10 to 15% per cycle. We know that for the first 4 cycles, that success rate is equivalent, but beyond 4 cycles, we see a reduction in the actual success rate. So I would usually not recommend sort of pushing cycles beyond 4 attempts at IUI. And the problem is IUI becomes an expensive, low yield process if it takes several cycles. If you jag it from the first or second, it's very cost effective. But if it goes much longer, it's not quite so cost effective. Minimum BMI. Okay. Minimum BMI becomes a health issue. If probably less important because low BMIs are much safer from the anaesthetic point of view and subsequent pregnancy. If it's because there's a gastrointestinal disorder, we've got to look at that specifically. If it's just because someone has a very low BMI because they're super fit or athletes, then sometimes actually increasing the BMI could actually improve fertility. But no, there's not an absolute minimum. So another question, once we get a referral, do we advise our GP we want to go with QFG? Yes, you do. In this day and age, there are some GPs who will say, who do you want to see? And there are some GPs who will push you in one direction for whatever reason or another. But yes, if you want to come to QFG, then yes, you say, can you please send me to QFG? And if there's a particular doctor you want to see, then obviously you ask. So as I said, different GPs will respond differently to those questions. Another question, does PCOS usually end in IVF? So for that question, not always. If PCO and anovulation is the only problem, so that we've got normal sperm, patent fallopian tubes in an otherwise healthy couple, and the only problem is PCOS and not ovulating, then ovulation induction is our prime target. So we make you ovulate. If you repeatedly ovulate and then don't conceive, then we've got to say, you know, the next question comes is, are your eggs all right? And the only way we ever actually see eggs is when we actually do IVF, where we actually stimulate the ovaries and take the eggs out. So short answer is some women with PCOS will end up with IVF, and more often if there's a male factor as well, or tubal disease or some other thing going on, and more often if they're particularly resistant to the ovulation induction agents. And there's a group of women with PCOS or polycystic ovaries who are very brittle, so that they either respond with one egg or they respond with 20, and they can sometimes be very challenging to titrate and get the low level response with ovulation induction. So there are certainly lots of women with PCOS that I've looked after who've had 1 or 2 cycles of simple either clomiphene or just oral ovulation induction agents of letrozole, who've had babies and had more than 1 babies. And there's certainly women with PCOS who have been very stubborn and challenging. And there are some with PCOS who have other things like endometriosis as well, which makes them a bit more complex. Age again sort of complicates just about every issue. Another one. Rightio. For the last comment, thank you very much. This is my first webinar, as I said. I'm sort of a novice to this, and QFG arranged it and sort of brought me kicking and screaming into the world of webinars. So certainly keen to. There's a lot of topics in this industry. Our big Fertility Society of Australia meetings in Hobart next weekend. And obviously after every big sort of conference, either in Australia or overseas, we always come back with new ideas and new thoughts. So yes, there'll be more of these. Another question, how long will it take for us to begin before IVF? Look, if we work out straight away that somebody needs IVF, either because of a male factor or a significant factor on the female side of things, the workup phase is usually within 3 or 4 weeks. So because sometimes some bloods we actually time at a certain time in your cycle, but we would see someone in one cycle and say, look, if you've got a significant problem that leads you to IVF, then it takes 1 month to work up, to do the genetic test, do each partner's genetic testing, infectious disease testing, and literally the next month we start. So most couples are starting from first consultation to actually starting a cycle, if that's what they need, probably in somewhere between 4 and 8 weeks. So repeat AMH, and the question now, repeat AMHs. Look, AMH should move very slowly unless there is something like an operation or chemotherapy or some trauma. AMH should be sort of consistent. I mean, over a reasonably sort of long period of time. If we were worried about someone, particularly someone at a young age, having a lower than normal AMH, we would probably repeat it in 3 to 6 months. You certainly wouldn't need to repeat one if it was done within a month or so, because you're not going to see a significant change unless, as I said, unless there was a significant event. So next question, counselling for single mothers. Look, with IVF technologies, there's some degree of counselling in just about everything we do. And the counselling is not meant to be restrictive or exclusional. The counselling is meant to be our responsibility to help you understand all facets of the process, and particularly when you use donor sperm, donor eggs, or there's more than one sort of person involved in something, understanding just how that implication, what questions children might ask in the future, what do you tell the children in the future. There are so many issues that most of us who aren't sort of counsellors aren't thinking about this all the time. So counselling is meant to be positive for the patients, and for us it's, I suppose, a part of our duty of care to make sure that everyone knows what's going on. Now, 31-year-old woman, opinion of falling pregnant through IVF. Look, at 31 years of age without a major medical problem, the statistical chance of an embryo transfer being successful is about 45%. And the vast majority of those will sort of progress on to be successful pregnancies, healthy babies. There's always a chance of miscarriage with any pregnancy, whether it be natural or assisted. But yeah, under 35, generally speaking, as long as your eggs are good, fertilise normally and make healthy embryos, 45% is our sort of benchmark. And look, for some women it might be higher than that, for some women it might be lower. So like with everything there's a spectrum, but that would be a pretty sort of reasonable assessment. And so that's sort of we're getting towards the questions. So I've just read off the ones that have come through. I think that there's always sort of 100 different things to talk about in this sort of realm, and some things are going to be relevant to some couples and not others, or to single women and same-sex couples. There's lots of different things. So I mean, I hope those answers have been helpful for some of you. There's always, where we look for things with in infertility, when we're looking for causes, we're always there are certain sort of further investigations that we sometimes need to do. And I was just sort of thinking, the reason I'm sitting here with a blue shirt on is that I've spent the day in theatre today, mostly sort of tackling, women with endometriosis, and most of whom will want to have babies. So some women will need laparoscopies or surgery before they embark on things. Another question, does sperm have an expiry date? Look, men can maintain their fertility much later in life than women, and it's one of the fundamental biological differences with the sexes is that men make sperm which are capable of fertilizing eggs well into their 80s in a lot of cases, and sperm are only ever 72 days old because they're constantly being produced, whereas, as I mentioned before, women's eggs are basically there in their ovaries 3 months before you're born, so that when you're 40, your eggs are 40 years and 3 months of age, whereas sperm still, from a 40-year-old man, is still 72 days old. So sperm in nature is, it doesn't seem to have the same sort of expiry date, and it doesn't age because it's constantly being produced. When we cryopreserve eggs and sperm, they have a similar outcome. So when we actually sort of freeze sperm, particularly if we're going to put it away, we'll always do a test freeze thaw just to make sure that the sperm we do freeze actually will thaw again and be motile and behave normally. Another question, male with liver function, increased ALT, gamma GT, increased iron level, fatty liver, ferritin. I suppose that the question that comes here with some liver dysfunction, probably the big thing is what the current semen analysis parameters are doing, and what the fundamental cause of that liver anomaly. If it's just a fatty liver anomaly rather than an infectious hepatitis, depending on other factors, it may or may not have an impact. I would like to see, as I said, a question that's come through, I'd want to see the sperm parameters before I sort of said, is that going to make a difference to things? So someone who was otherwise fit and healthy and would excluded serious causes of liver dysfunction, other than just the fatty liver, then you'd have to take note of that. The other question is, if that ferritin's that high, are we dealing with hemochromatosis or some other genetic condition where there may be some way to sort of medically optimize that scenario? So you'd have to look. There'd probably be more to that picture for that lady who sent that question in, and I would encourage anyone with those parameters to make sure that they've had a full medical workup to make sure that nothing's being missed. But hemochromatosis jumps to mind, acute fatty liver jumps to mind, and ruling out infectious causes would be important. So next question, sperm donors. Look, sperm donors are basically screened meticulously well for genetic abnormalities, cystic fibrosis, carriage of known genetic or sort of communicable diseases, obviously, and the same sort of the same sort of meticulous process is applied to sperm banks from overseas that we actually import sperm from. The problem is that we're dealing with millions and millions of sperm per mil, like at least 15 million per mil, and they're all a little bit different. So we can't actually screen each sperm, obviously, for genetic abnormality, and so it's not something that's possible to do. And if you actually took the genetic load out of a sperm, you'd actually destroy the sperm in the process. So even if it was possible, the answer is sort of no. You can do testing on looking at the proportion of genetic abnormalities, I think, called SCARs or sperm chromatin DNA assays, but you can't actually screen each sperm for a problem. Fatty liver disease, chance of pregnancy, look, depends. The question there would be how much impact it is having on the other sort of general health and well-being, and is it a reversible scenario? Like most conditions that are reversible, we'd recommend that you optimize medical management before you embark on pregnancy. And if it's something to do with diabetes, congenital lipid disorder or something, if that's optimized, then subsequent fertility is going to be sort of better as well. After falling pregnant with IVF, would there be more testing afterwards than basic tests? Look, short answer is not necessarily. Babies that conceived after IVF technologies, once you're pregnant, the pregnancies are, for the most part, managed exactly the same. So once the embryo is implanted, then we sort of tend to treat you the same as anyone. Most of us in this business don't like pregnant women who've conceived with IVF to go overdue, because there's a little bit of some evidence that's suggesting that they may be at slightly higher risk of post-term problems. Everybody with IVF pregnancies gets diagnosed very early, and we get an early opportunity to counsel about certain screening tests, particularly now with non-invasive prenatal testing, which are blood tested 10 weeks of pregnancy, looking for Down syndrome, genetic abnormalities, and doing early ultrasounds to check. That's not because IVF pregnancies need them more than others, but it's just that we're seeing them so early because we're doing a pregnancy test straight away. We're doing early ultrasounds to check that things are starting off normally. And yeah, but they don't need additional testing officially. We know that there's a very small chance, if you look at all bubs born from assisted reproductive technologies, either IVF or ICSI, that there's a very slight increased risk of minor and major malformations, but we're talking like barely 1% difference. So the normal screening test in a pregnancy would be picking up the things that we're looking for. So I think we're coming up to sort of, whoop. We got another question in. Would having HSV2 virus affect any chance of pregnancy? No. Herpes virus, incredibly common. The only impact on HSV, on herpes viruses, is really at the time of sort of giving birth to the child. There's no evidence that it actually reduces fertility. There's no suggestion that it actually affects the development of the baby or the progress of the pregnancy. But we know that if a mother has an outbreak of herpes virus and goes into labour or a waters break, then there's a risk of exposure to the baby at that time. And so there's much higher likelihood of needing a cesarean section to avoid that exposure. But it really doesn't have an effect on fertility, and it wouldn't affect us from an IVF point of view. Elevit and folic acid. Look, Elevit is really our standard go-to vitamin. This day and age, it had the most research done on it. The 800 milligrams of folic acid, the 800 micrograms of folic acid in Elevit is adequate for most scenarios. There are some scenarios where a high dose of folic acid is recommended in epileptics or some malnutrition syndromes, or people who've had spina bifida or abnormalities. So you'd add an extra 5 milligrams of folic acid. And there are some scenarios where people have an anomaly of their folic acid metabolism pathways, and there are some people who probably do better if they have a different sort of form of folic acid called folinic acid, just because of their genetic makeup, and that's going into MTHFR genes, which is still a contentious issue out there. Not everyone sort of believes in them, but there are certainly most people would be advised Elevit. A few people would be advised variations of that multivitamin. Personally, if I do know someone's got an MTHFR anomaly, then I tend to sort of to guide them towards a multivitamin that has folinic acid in as well. And as I said, the high dose folic acids are for the people who've had spina bifidas, neural tube defects, potential sort of abnormalities in the past. If I wanted to look at IVF next year, would it be worth taking prenatal vitamins and medications now? Look, probably 3 months before you're planning to start would be a good idea to have a dedicated prenatal vitamin. Obviously, all lifestyle modifications should start immediately that you're thinking about it. But 3 months, there's no advantage more than 3 months out. And some would say maybe even a month is adequate. And the whole sort of thing on sort of vitamins, there's a few other things that are sort of adjuncts which we think we tend to use a lot more. Things that vitamins like CoQ10, which is we know is a metabolic enhancer vitamin, part of the sort of metabolic pathways we tend to use a little bit more often. There's some evidence for it. There's not great evidence. There's a lot of other adjuncts and things mentioned on the internet which simply don't have good evidence for them, unfortunately. So the basic thing is a good balanced diet. The good thing about it in Australia is our licensing is so strict that any multivitamin that has pregnancy, breastfeeding, prenatal on the label has to have certain, the correct amounts of certain vitamins, whereas normal adult vitamins can actually have higher than recommended levels of some fat-soluble vitamins, particularly vitamin A. So it's important that when you're using prenatal or pregnancy vitamins that you actually sort of make sure that you've got appropriately labelled products. Another question, is there an option to help my sperm donors swimmers? I suppose the question is there a problem? Like, there is a men's multivitamin out there called Minovit, which is the partner of Elevit. It was designed by a reproductive unit down in South Australia, specifically when they were sort of given the mandate what vitamins and antioxidants and herbs and things that should go into to optimize men's sperm production. We know zinc and antioxidants and selenium are really important. But we also know that vitamins don't necessarily help unless there's a deficiency to start with. So other than general lifestyle, if there's not an overt anomaly, then like a lot of things, there may not be a clear sort of improvement. A lot of people, the joke always is that if you're not vitamin deficient, then vitamins make expensive urine. But if there is a vitamin deficiency, then correcting it's really important. So I think we're coming up to 9 o'clock now. That's a whole hour, which is a lot longer than I thought I'd last on my first webinar. But I think I'll sort of move towards signing off. But I'll answer that one last question that's come through. It's an egg transfer in a hospital or a clinic. Now, in this day and age, IVF clinics have very highly specialised laboratories, so much so that they often have their own air supply, special air conditioning, special airflows. So the environment that embryos are cultured and grow in are extremely precise. And in that same sort of scenario, the environment where the embryo is transferred is got to be close to that laboratory. So there is minimal, basically, time out of that optimal environment. So it is, our transfer room is basically right next to our laboratory. So the embryos literally move from one humidity crib to the next, and they spend almost zero time in the open air. And so they stay basically in optimum circumstances. So we happen to be located on a hospital site, and in our little building, we've got a day surgery on the ground floor. We've got most of the doctors on the first floor, and the whole embryology laboratory, as well as the nursing and the consulting units. And that's all at Pindara Private Hospital, and it's all a one-stop shop. Everything's close together, and it just means that as I said, the embryos stay in optimum conditions, don't need to move around any more than is absolutely necessary. So with that, I'll say thank you very much, everyone who's out there listening to me, and hopefully I'll get an opportunity in not too distant future to put another one of these together, and perhaps even an update after the upcoming Fertility Society of Australia meeting might be an opportune time. So thanks very much for your attention, and I hope it's been helpful.